Thank you everyone for coming to our CHEP seminar this week. We're continuing our unbroken record of rainy Thursdays. We have Kevin Schnepel here today from Simon Fraser University. Kevin does work on health economics and the economics of crime. It's published in the American Economic Journal Applied, Review of Economics and Statistics, Economic Journal, Journal of Public Economics, where we all pray we can one day publish. Today he's going to present a cool new working paper with Tim Moore on looking at the effect of a heroin shock in Australia. Thanks so much for being here.
Great. Well, thanks, Joe, and thanks everyone for the meetings today, and it's been a very engaging day. I was telling Joe, I feel like I've been talking non-stop since about 9 a.m., so hopefully I can sustain through this talk, but it's been very fun and a great engaging place to be. And I don't mind. I'm coming from Vancouver, and so today, I guess as long as the sun peeks through the clouds, and you know, it's a beautiful day for me up here. So this is, as Joe said, this is joint with Tim Moore, who was so both Tim and I used to be in Australia last year. So he was at University of Melbourne, and I was at University of Sydney, and we've since migrated to North America. Tim's now at Purdue, and several years ago, we started talking about a project to re-examine or re-evaluate a very large and well-known shock to the heroin market in Australia. And so I'll be presenting that work today. And the paper, I apologize, the paper that is circulated and you all have in front of you, which kind of makes me nervous because it was a pretty rough draft. But there's a lot of updated slides and pictures, and we're working on a more complete and finalized working paper that should come out in the next month or so. So stay tuned for that, I guess. So I'm going to start by showing you what was going on in New South Wales and in Australia in general. Most of the data we're going to be working with today is from New South Wales, and I'll talk a lot about the nature of the data. It's going to be administrative data. But some of these aggregate pictures are, this one at least is depicting the trends in New South Wales. And what this orange line is showing is the opioid-related deaths for 100,000 individuals. And this, one thing to note about this, which would be different if we were to, and I am going to overlay a plot in the US, but these opioid deaths in the 1990s in Australia are almost entirely heroin-related. There's not a problem in Australia at this time with prescription opioids or with the current fentanyl issue that's happening here in the U.S. and in Canada. And it's also at a time, so you can see here that there was this really concerning escalation of deaths per 100,000 individuals in Australia. And what was happening also, along with this, was very widespread participation in methadone prescription programs. So harm reduction, addiction management type programs, and I'll talk more about that, and that's where our data is going to be coming from. If you look at, just to highlight how concerning this increase in opioid-related deaths was, this really was a public health crisis, and known and described as an epidemic at the time in Australia, and so it eclipsed traffic fatalities as the leading cause of death in the late 1990s. So this was the number one, I guess, mortality issue, especially for younger Australians in the 1990s. If we overlay the US opioid death rate from, and I didn't kind of magically make these numbers overlap, it just happens to work out that way, but from this would be for the period 2007 to 2015 in the US, or 2007 to 2016. And so over that same period or that same time horizon, it looks quite similar in terms of the growth rate and the nature of this public health problem in Australia that we're experiencing now in the US. And so we think that it's good timing for this work in the sense that there's a lot of discussion and a lot of policy discussions around what to do about this and how we can address this epidemic. And we think we have something to say about that. So what happened, or what is this paper about? If you look at, there's this alarming death rate in the late 1990s, just before 2000. All of a sudden in 2000, and this really happened late in 2000, so December 2000, think of as the onset of this shortage or this supply shock or rapid reduction in heroin availability and increase in price. This is what happened to the opioid death rate in Australia over this time horizon, 1990 to 2008. So you can see this really large reduction over the period 2000-2001. And I'm going to talk a lot about what we think caused that, but mostly what this paper is about is looking at, for the individuals who had opioid use disorder or addictions, as we're identifying through the data, how did they respond to this massive reduction in availability and supply of heroin late in 2000 and through 2001. And I'll give you a picture here of kind of what the market was for heroin and how that changed very rapidly into the late 2000, early 2001. So what's plotted here, and the numbers are on the right axis here, would be the purity adjusted price per cap or per dose of heroin. And so this went, and the street price didn't go up this much, but again, this is adjusted for purity. So what happened is the street price of a dose went up and the purity went way down. And so the purity adjusted price was around $50 per cap during the heightened part of this crisis. And that went up to about $250 per cap over the course of, and this happened, it happened at the end of 2000, so most of the change was right at the end of 2000, early 2001. And if you look at surveys of injecting drug users, and I'll show some of these statistics, this happened very, very rapidly. So it's thought, over the course of a month, the purity adjusted price of heroin went up by about 400% or over 400%. One thing to note that's important when we're looking at outcomes in this presentation is that it never really recovered. There was a spike here, it came down, but if you compare kind of the pre-shock or pre-shortage prices in market for heroin to what's going on post here, you don't see this, it's not that a few suppliers got pushed out and then more suppliers came in. There was a sustained supply reduction.
So in the last graph you overlaid the U.S. death rate in here. If we did the same thing here, would it stay high, or?
With the price of heroin in
No, just the death rate, because obviously it goes down in Australia. Is it, in other countries, is it following the same pattern, or is Australia unique?
So the U.S. this was a different period in the U.S. This would be the more recent period.
Gotcha. All right.
And this would be going up further if I looked past 2016, mostly due to fentanyl, or fentanyl is increasing the overdose risk. And so if I continued that overlay, U.S. would continue to climb, but we're hoping this paper can, help. Not really, it's somewhat of a joke, but to help inform kind of if there were by some miracle, really effective supply side enforcement in the U.S., what types of effects will we see potentially with the individuals who are addicted. In terms of the price, I don't know about that's why I was writing that down. I need to think about how this price per cap compares in the U.S. Okay, so rapid change in heroin availability. I won't go to this jump out here, but you can show that in a lot of different ways. You'll see it through the offending data in terms of opiate arrests for opiate offenses, opioid-related offenses. You can also look at ambulance call-outs, and you see this really dramatic reduction over this late 2000, early 2001 period. About a 400% increase in the price of pure heroin, purity adjusted price of heroin, and this is attributed to drug interdiction. And so there is somewhat of a debate in the public health community in Australia as to what exactly caused this. From our perspective and from reading through this debate and this literature, the most likely explanation, and I'll show some statistics around this, was international or federal level drug interdiction efforts. And it was quite effective, and I'll talk about why we think it was effective in this context. And the major supply routes of heroin into Australia were disrupted and maybe even dismantled. And this is, there were some very large, 3 in particular, very large seizures of heroin being imported or brought into the Australian market in 2000, early 2000. So what do we do in this paper?
Sorry.
We're going to, yeah, Joe.
So how did Australia sort of avoid the prescription painkiller sort of a problem? Were prescription rates relatively low to begin with? Was there stricter regulation? What about, because this is the period, right, in the late 90s and the early 2000s in the U.S. where things started exploding for opioid-related deaths due.
So my impression was this was later in the 2000s in the U.S., but it started in the 90s.
It started in the late 90s and then it really took off. Started in the 2000s.
So it was more in this period.
Yeah, that's right.
And I think that it's actually interesting, just as an aside, with Australia, kind of illicit drug problems or drug public health problems. Heroin was obviously a big concern in the late 1990s. This was coincident or at the same time as the huge methamphetamine concerns in the US. And what happened in the 2000s in Australia was there was a big increase in ice or methamphetamines and concerns about that. So it kind of flipped where Australia was really concerned about meth in the 2000s and the US was then concerned about opioid and particularly the prescription painkillers. There is a lot of discussion currently about concerns about prescription painkiller over prescription of painkillers in Australia currently. They're now having discussions about that and the relationship with other opioid use, and I'm not an expert on kind of what's going on specifically, but I know that's part of the public health and drug policy discussions. Okay, so what are we going to do in this paper? We're going to use this very rapid and fairly sustained reduction in heroin availability to identify or study the impacts of heroin supply on health and crime outcomes over this 8-year period. So we're going to go through 2008. And the way in which we're going to do this is this took a while to get access to, but we've been able to get administrative data at the individual level of almost 30,000 individuals who we know to have some sort of heroin or opioid addiction-related problem because they were assigned or participating at some point in this pre-period, so before 2000, and we can go all the way back to 1985 with that data. So they had some participation in the methadone prescription and opioid substitution therapy program. And so we can take all of that administrative data from that agency, and we've been able to merge that at the individual level with criminal offending history, so court data, mortality data, and we do have other health data sets linked in, so ambulance calls, hospitalizations, things like that. But for those other health agencies, we only have information from 2002 on, and we haven't yet used much of that information because we don't have it through this shock. So what I'm going to be presenting today is the health outcome is going to be mortality, and we can look at different types of mortality and criminal offending as observed through the arrest and court charge data. But it's a large population, and this captures this population of individuals that we can track. Based on our estimates, is accounting for about 70% of the total opioid-related deaths in Australia during kind of around this time period, around 2000. So we're capturing the majority of heroin users in Australia with this data set. And what I'm going to present today, the primary kind of graphs and model is going to measure effects using an event study design. We know this is limited in how we can interpret these differences over time, but I'll talk a lot about what we're going to control for and what the general trends look like over time, and then where you can further assess this using, and this will happen at the very end, but we also have, so not only can we track these individuals that participate in methadone pre-shock through to 2008. We can also construct similar longitudinal panel data set of individuals who had some sort of criminal offending history prior to the shock, and also map them and track them through who didn't participate in any opioid substitution therapy program or have any opioid related arrests. So it's a way to construct, and this isn't perfect kind of control group, but it's a way to construct a group to try to pick up any other major events or trends that might be driving some of the patterns we see in terms of crime and health outcomes for this group. So I'll talk about that and may show some pictures at the end for that group. But that's still in development in terms of thinking of the best way to do this, because they're obviously not going to be, perfect. We're not randomizing heroin addiction here. Yeah.
So is this the universe of people who participate in these methadone clinics?
For the universe of people who participate between 1985 and December, or I guess we're going through the third quarter of 2000, so September 2000.
So the universe of people who participated in that,
yeah,
kind of
at some point at any sort of assignment to this methadone prescription program.
I see.
And I think it's conditional on them actually showing up at least once to get a prescription. So I'll talk more about the treatment, but yeah, we're capturing everyone. And this is Australia. This is one way in which this setting is very different from what the U.S. looks like now, because it is a very generous or easily accessible program in terms of getting, that was one of the main strategies to deal with this epidemic, and even starting before that in the 1980s was to use these methadone opioid substitution therapy type programs. So methadone and buprenorphine, I think is, if I'm saying that right. Is there another?
Do you have any differential supply shocks within Australia, or is it just?
Yeah, no, I mean, there are areas where this was much more heavily concentrated, but that's, we thought about using geographic variation. This was a nationwide shock. So if you look at data from Victoria, which would be the other main area where this epidemic was quite concerning, you see very similar patterns. We don't have, unfortunately we don't have heroin addicts in certain places in Australia that didn't experience any sort of market disruption or supply shock. And so we don't have any nice counterfactual of kind of users that would be similar to these individuals that aren't affected by this major change that we see. And so we haven't been able to exploit or use any sort of geographic variation. Think of it as a national shock to the supply of heroin. And prices went up everywhere that people were using heroin. And so the one thing to note is that, so what we're going to be measuring through this event study design and the difference in difference would be reduced form effects of just estimating the effect of these different time periods on the changes in behavior controlling for a lot of other determinants of changes we would expect in terms of crime and health outcomes. Zach?
What was the opioid mortality trends looking like in New Zealand, say? Like, I don't know.
In New Zealand?
Yeah.
That's a good question. I have no idea. I don't think, I haven't heard that they were experiencing a similar epidemic, and I don't know why that would be the case, if they had stronger enforcement or if they're just, weren't as susceptible to these changes. I know there has been discussion as to, so the heroin, and I'll talk more about this, the heroin in Australia is coming from the Golden Triangle, so Myanmar, Burma, or formerly known as Burma, area would be where most of the heroin is coming from. And that was also where a lot of the heroin in, say, Vancouver was coming from at the time, and there's been some estimates or some look at whether there were similar shocks in, say, Canada, and there's not as good of data and not as much evidence that there was a major shock to Canada. But we can talk about that in more detail, and I don't know about New Zealand, but I'll look that up. Preview of findings, and I'll be able to show a lot of these in pictures, and it'll be very clear that there's something going on, and most likely, or we think is definitely related to this disruption to the heroin market. So we see very immediate and persistent declines in heroin mortality overall, heroin possession. So think of this as kind of the first stage in the sense that, obviously with the price changing like this, we would expect to see reductions in use, and we do in the data set that would be a proxy for use. Yeah.
I don't know how heroin works, but did
Neither
it
do I.
decrease the quality, the quality of the heroin, or was there just a general? You were talking about a per cap price,
Right.
Were
So
they-
there was increase. So if you went onto the street to buy a dose of heroin,
Yeah.
you would be paying. So it went from about paying $35 for a dose to paying $50 for a dose. But that dose you're paying 50 for was much less pure. So there was a decrease in purity, which is important to think about in terms of the mortality and overdose risk, because it could be that people are still using, but the risk of overdosing or dying from that is much lower. That said, when we look at arrests or charges for opioid-related offenses, we also see a very, very large decline, suggesting that, and in terms of the surveys, it is very clear that the availability of heroin was much more scarce. And the stuff that was around was different in quality for sure. So big declines in the heroin-related use or possession type outcomes. We see these really interesting dynamic patterns, and this is what I think is the most interesting part of the project in terms of criminal behavior and how crime responded to this market disruption, this rapid reduction in heroin supply. And so across all crimes, violent, property, and other drugs, in particular we're going to focus on methamphetamines and cocaine, huge short-term increases in these types of crimes and behaviors. A lot of that is returns to a baseline after about a year, but then property crime is the one that continues to be, seem to be affected by this reduction in the supply of heroin. And so I'll show you a lot of pictures and coefficient estimates around this and talk about why we think this might be the case. And then I'll get to your question in just a minute. The only other point I want to make here is in terms of the results that I think is quite interesting, especially with respect to kind of policy discussions in the US and how to deal with the current opioid epidemic, is that what we're going to do in this context of individuals, a lot of individuals being treated by the opioid substitution therapy, there's this supply side disruption or enforcement that reduces the availability. We're going to be able to look at, for those that were on the methadone prescription when that shock happened, and this was largely, we don't have any evidence that this was anticipated by the addicts or users. So for those that were on methadone when this shock happens, we can look at how they responded versus how individuals not currently in treatment responded, and find very interesting differences in terms of these crimes. So property crime and violent crime. For the ones on methadone, individuals on methadone, at the time of the shock, we don't see any sort of short-term increase in property crime and violent crime, which suggests that these harm reduction policies can help mitigate the short-term costs of any sort of supply-side enforcement or policy. Question? Yeah.
I was just going to ask if the sort of substitutability between like uppers and heroin has been very well documented before. It seems sort of surprising that you'd see such a...
Yeah, so and I was talking to Hashim about this earlier today. We were very surprised by this. These are very different substances in terms of their pharmacological properties and the effect they would have on individuals. What I think is going on here is that, so the problem is mostly injecting drug users and street users of heroin, and oftentimes there might have been combinations or combining heroin with cocaine and these other substances, and the dealers would be dealing, poly drug dealers, I guess, dealing lots of these substances. And so what I think helps to explain this increase in cocaine and amphetamines, or the story at least I think that is most consistent with what we see, is that for the addict that was going to the dealer and looking for heroin, the only thing that was available was cocaine and amphetamines, and that was what that person ended up taking. And I think there's an interesting potential connection here with the patterns in, say, violent crime that we see, that the connection between cocaine and amphetamine with more violent and abusive or impulsive behavior is stronger, I think, in terms of the way in which those types of substances affect your behavior in your brain. But the substitution, I think, is, I don't know if there are any drug policy or drug experts in the room, please chime in, but I don't think it's all that surprising that you would see this transition to these other types of substances, and maybe this is why we see such a short-term transition, because the substitution effect, if you're looking for a certain high or a certain feeling and you're not getting it from these substances, that might not be something that you persist or use for a longer period of time. It might just be a way of getting through that initial shock. But we can talk about that later when we see some of the patterns too. I'm going to go through quickly what time do I have until?
45, so 45, 50.
Okay, yeah. I'm going to talk briefly about the contributions. I'll show you a slide with a bunch of citations, but I won't talk a lot about the existing literature, highlighting a few studies. So what we see as the key contributions of this project, one is to provide some evidence of how a supply side enforcement can affect illicit drug use and markets, and there's a lot of work on this, but the evidence, I think, from the economist's perspective is quite limited in the sense that it's very rare to have exogenous shocks and large enough changes to try to identify these supply side enforcement effects. And I see Joe nodding, which is good because he's a drug policy expert, one of the drug policy experts. But we think this is, and I'll talk about there's a literature in the US on the effects of the methamphetamine supply shock, and we see this as being analogous to that literature in terms of the size and magnitude of the shock and the opportunity to use that major change to evaluate the effects of kind of reduction in availability and increase in price on these types of outcomes.
And even those shocks were more short-run supply shocks, right? And
yeah,
so
they weren't as
unique,
persistent.
yeah.
And they don't find similar effects on crime behavior. They also don't have as detailed of individual level linked data, and so it might be harder to detect those crime effects. Yeah, they were less persistent. Second, assess how change in opioid use can affect the use of other drugs and overall health to the extent that this shock is reducing the opioid use amongst the affected individuals. And this is where this individual level longitudinal data really allows us to do this in terms of following them over time and following them through these periods of reduced availability. Insights into the causal impact of illicit drug markets on property and violent crime. There's a lot of research on the connection between drugs and crime, but again, it's a hard relationship to identify, and it's not clear from theory whether what direction you would expect these effects to go in. So they're ambiguous in terms of the expected effect on criminal activity, which would be one of the major costs in terms of considering different policies affecting illicit drug markets. And then finally, which relates to the heterogeneous effects across those who are being treated versus not, one of the contributions is that we have this situation where there's this large shock, but we can say something about the mix of policy in terms of the supply side enforcement versus the harm reduction camp, and it seems like some sort of mix could be the most effective to limit any sort of costs caused by the disruptions to these markets.
Excuse me, is property crime and acquisitive crime the same?
Yeah, that's what acquisitive crime would be: property crime, theft, breaking and entering, and yeah, that's what we mean by that. Okay, so this was a slide to see if I could catch anyone in the room looking for their name. See Joe scanning it. So there's a lot of related literature in these different areas. I'm not going to go through this in detail. I think I'm going to just highlight a few areas we think are most important for what we're doing. And as I mentioned, the U.S. methamphetamine supply shocks, there's several studies looking at what happened. So there were very large disruptions to the supply of methamphetamine in the U.S. in the late 90s, early 2000s, caused by efforts to address or limit the precursor chemicals and rates of manufacturers of those chemicals that were being used to cook meth and make meth. And this was very well documented in terms of the large effect it had on the price and availability of meth. And there's been several studies that have looked at the health and crime effects of that. Find very large improvements in health in terms of overdoses, not very strong effects on criminal activity, property crime, or violent crime. And as Joe mentioned, it wasn't, these shocks were very large and very immediate, but they were not persistent, and that the market seemed to recover after several months or within a year. So there's several areas where that shock is used to say something about these different topics. There is also work that has looked at this Australia heroin shortage, and most of these are published in public health journals like Addiction, and as well as some Bureau of Crime Statistics and Research reports. And it starts off by looking at the aggregate changes and documenting kind of how things changed in aggregate in Australia around 2000 and attributing some of those changes to the heroin shortage. And there's also been work that's looked at health outcomes and crime outcomes, but again, looking at mostly aggregate data and not, if they are using individual level data, it was mostly a focus on that very short-term effect of these shocks, where we're able to extend, for a much larger sample, extend this out for a longer-term period. And that's, the literature I'll highlight there, but there's a lot of other work obviously done on these topics in terms of law enforcement and drug markets, drug substitution, health outcomes, and the relationship with crime between these markets. Okay, so I'm going to go through the background quickly. I think I've said a lot of this before. One thing I want to mention is Tim was actually involved in a lot of work before he went on to a PhD. He worked at a drug and alcohol research center where he documented and worked a lot on this topic and what the drug markets look like in Australia and how things changed after this heroin shortage. So he's been an expert in this area for a long time from the economic side of things, and was happy to return to this project. The illicit drugs in Australia are similar to other developed countries. Policing is done by state level agencies, and then the federal government is responsible for drug interdiction, which would be similar to here in the US. Most of the social problems in Australia are thought to be associated with near daily injecting drug users, especially at this time period. So most of the problematic behavior and overdoses and crimes are from very, very frequent users, and often using on streets or in public areas. Typically polydrug users, and so in recent years there's more common use of both heroin and methamphetamine. So this gets to the point earlier about substitution. I think a lot of these drugs or a lot of individuals, addicts, are polydrug users and might use these substances in combinations. And similar drug mix to other developed countries. Australia was unique relative to other countries in terms of its emphasis on harm reduction. So naloxone, needle exchanges, the methadone, those types of policies were very widespread in the 90s in Australia. The opioid pharmacotherapies in Australia, so this is what I've been describing as the methadone maintenance or methadone prescription. This was endorsed in 1985. This is when our data starts, and national guidelines were operational since 1987. This is prescribed by drug treatment clinics and general physicians. We're still gathering more information on exactly how hard it is for people to enter into these programs, but the access is fairly widespread, especially compared to other countries. Some are on buprenorphine, but most of it is methadone. And this is typically, the typical method would be that it's dispensed daily under the supervision of a pharmacist or nurse. So there are pharmacies that are licensed to dispense this, and then the users would go into that pharmacy and take if they weren't a takeaway dose, they'd be taking them under the supervision of the pharmacist. Methadone is covered by the government in terms of doctor clinic visits, but recipients, there may be a small cost or about $30 per week for the dispensing fees for these types of pharmaceuticals.
So if you compare the United States and Australia, what percentage of heroin addicts is taking methadone in Australia versus the US?
It would be a huge difference. So I think the estimates in Australia that I've read are that they're capturing at some point, it depends if you look at it as a total number of people that have done this at some point versus like at the current period of time. But in terms of the methadone prescription, it's estimated that over 90% of heroin users would have had methadone or some other similar treatment at some point in time. Whereas in the US, I think that would be less than, I don't know, but I think it would be way less than 10% and probably less than 5%.
And has anybody examined how the availability of methadone treatments affects the demand for heroin, because people figure, oh, it's not such a problem, you know, I have a 90% chance of getting methadone and that will calm me down, so I might as well start heroin.
I have not seen that yet. I know there's some related concerns with naloxone in the US in terms of access, and Joe's worked or been involved in some of this work, so whether naloxone lowers the cost of using drugs and then you see more people using drugs is, I don't know, and maybe there's conflicting results, I guess, in papers. And needle exchange, there's a recent working paper that's looking at the availability of needle exchanges and potential unintended consequences in terms of use, lowering the cost of use. I think that the public health community pushes back really hard on these types of results and things based on their knowledge of how these markets are working and how people are making the decisions. But I haven't seen anything with methadone availability, but there could be something out there. I don't know if you're aware of anything, Joe, but yeah, it could be, especially in a place like Australia, it could be something. We're thinking of potential other projects with this data, and that might be something that we could look into.
But this is important, given the high participation rate. You don't think you're not presumably as worried about a select sample of heroin users.
Right.
You're sort of identifying.
Yeah, and it's not that we're conditioning on them being treated when this shock's happening. Right. We're looking at heterogeneity across that, but we're just using participation in this to get a sample. So that one of the key kind of innovations of this data versus looking at aggregate data is that, or looking at crime data, for example. So we could have taken a sample of individuals who had some sort of opioid-related charge, criminal offense charge. That would be a much smaller fraction, and it would probably be a sample size of 5,000 versus nearly 30,000 individuals. So we're capturing a much wider part of the population that do have heroin-related or opioid-related problems, but do not have much involvement in the criminal justice system. But we think we're capturing most of the heroin users. Heroin in Australia during the 1990s. So early in the 1990s, the way in which heroin was coming into Australia was mainly on reliance on drug mules on flights and individuals smuggling. But then through the 1990s, it became very heavily concentrated amongst a few, thought to be as few as 2 key suppliers in terms of Asian-based crime organizations, and they were bringing them in and bringing the heroin in shipping containers in the late 1990s when we saw this escalating epidemic. And the total heroin market, because it's Australian, there's not very many people in Australia, small relative to other countries, and so these disruptions, the seizures that I'll talk about, the large seizures, were had a very large effect on the total supply of heroin in Australia. Purity increased and price decreased through the 1990s, so there was heroin became cheaper and it became a higher quality product for the street users, or the injecting drug users, and it was the most commonly drug used for these injecting drug users. Just to give you a sense of how available or easy it was to find heroin in mid-2000s. So this is just before the rapid reduction. There was a survey of injecting drug users, and 99% of them reported that it was easy or very easy to obtain heroin. And you can compare that to this survey, the same survey the next year, found that where 88% of these injecting drug users answered that heroin was difficult to obtain. So it went from easy or very easy to difficult for pretty much everyone amongst this survey in New South Wales. And what caused this? So what we think is the most likely explanation would be the expansion and increasing in the drug interdiction resources at the end of 1990s. And so this by the Australian Federal Police. So it led to major seizures, arrests, and dismantling of this supply infrastructure. And there's some discussion around the specifics of that. The seizures in particular, there were 2 seizures in the Sydney port, heroin that was coming into the port, each over 100 kilos, which is quite large relative to the overall market, in 2000. And then in October 2000, there was a seizure of 350 kilos in Fiji, so cooperating with the international enforcement agencies. And that was thought to, most of that was thought to be headed towards Australia. And so this is the likely reason for this shortage. There's been other explanations, like especially during this time period, oftentimes people will cite or talk about the Taliban and the war in Afghanistan as being a major shock to the heroin market. That happened in 2001 and was later, or later 2001 into 2002. But one thing to note in Australia, at least most of this is maybe related to the persistence of the shock, in terms of there was nothing that came in immediately after to fill that gap in the unmet demand. But this is not the area that most of the heroin was coming from in Australia. That was being sent, I think, more to Europe or potentially the US. There was also increased demand in China at the time. And so what the most likely story, I think, that's been discussed in this literature is that there was these large increase in enforcement, and think of it amongst a few criminal organizations, and so dramatically raising the cost to bring heroin into Australia for those organizations, and that coincided with increased demand in China. So in terms of the persistence, I think these things might be important, but in terms of what happens in the short term, it's mainly just disrupting the supply of these 100, 200 plus 350, so over 500 kilos of product coming in. Okay, so data. I've talked a bit about the individual level data that we're going to be using. So it's coming from the Bureau of Crime Statistics and Research in terms of the individual level offending data, and then from various health agencies for the other data. And so this is every individual in New South Wales between 18 and 64. I think we actually have relaxed this age restriction, who participated in this opioid treatment program between 85 and September 2000, so before the fourth quarter 2000. And we're going to look at outcomes through 2008, just to give you an idea of what these individuals look like on average. And this would be based on the average in terms of our pre-period, which is restricted by the crime data, starts in 95. But people could be part of our sample that enter into treatment earlier than 95. But in terms of the period we're analyzing, it's from 1995 through 2008. They're around 32 years of age on average, about 30% female, 10% indigenous status. The annual mortality rate is about 3%, so 3 per 100 in this pre-period, which is very high for mortality rates. Most of that's coming from opioid-related mortality when we look at the cause of death. And then about 10% of our sample is dying between 1995 and 2008. And about half of that is due to opioid-related mortality. The offense rate is very high. So the average annual number of offenses is about 1 per person. And a lot of this is property offending, which you'll see this clearly in some of the graphs I'm going to show. Okay, so a lot of pictures that'll essentially tell the story that a lot of the coefficient estimates will confirm. Mortality rates, so this is splitting the total mortality that we see in our, so now we're transitioning not just aggregate data in New South Wales, this is our 27,000 estimation sample that we've created this longitudinal panel for. The opioid related mortality is the solid black line here. And you can see, and the way most of these, or all of these graphs are designed is that the dashed period here in gray is the fourth quarter of 2000. So this is the onset of the heroin supply reduction. And then this gray period would be the 2001 year. So, and we think of this as kind of the short-term period or short-term effects. And so we'll see that throughout these graphs. And so you see a very sharp reduction in opioid-related mortality, which is consistent with both the aggregate figures from New South Wales as well as the opioid offense drop from, an average of 0.03 to about 0.01 after 2001. And one thing that will be reflected in the first table of results that I show is that, so one concern in terms of if we were just looking at opioid-related overdoses, and some of the prior research focusing on the short-term period has looked at opioid-related deaths and not other types of deaths. So you might, there could be a competing risk hypothesis of, they're not dying from opioid-related causes, but maybe from overdoses for other substances or other types of behaviors. And especially in that short-term period where there's heightened use of cocaine and amphetamines and violent behavior, we might think of there being more deaths due to those causes. We don't see any sort of huge increase in other types of deaths, and so the overall mortality effect is quite strong and driven by the opioid-related mortality. Property offenses and violent offenses. So you see here the property offenses is pretty stable or level. And the reason property crime is going up over this period, but remember, and I'll note that the way in which we construct our estimation sample and the panel for each individual is that they enter when we see them for their first treatment episode. So for individuals, and then they exit either when they die or at the end of 2008. For individuals that enter treatment prior to 1995, they would just be, their first observation in our panel would be first quarter of 1995. And so we have a pretty flat, high rate of property offending for this treatment sample in this pre-period, and a lot of the increase and this is true for opioid-related overdoses, and this might be surprising, I guess, based on the aggregate picture that we saw that opioid deaths were going way up. The reason this is flat is because of the nature of our panel, right? Because we have, in each period, what's the probability of someone that we're observing dying, whereas that sharp increase is just new opioid users entering, or new users entering in, and so having more and more people using opioids. So we see a pretty flat effect on property crime in the pre-period. A sharp increase here right at the fourth quarter 2000, so when the onset of this rapid reduction in the supply of heroin. But that was very short term, and then in the long term we see a very large reduction of property crime. And these figures are not controlling for anything. And so one of the reasons you see things decline towards the end is on average people are getting older, and so we see lower rates of crime for older individuals. And so part of this is the age crime curve, but we're going to be controlling for all of those factors. So controlling very flexibly for age, demographic characteristics. We can even include individual fixed effects and see to what degree we think this decline is unexplained by those factors. Yeah.
So you bring up an interesting point. I wonder, given that everyone who's in your sample is they're like nearly daily heroin users, it sounds like.
Yeah.
We have this kind of mortality attrition going on in this sample. And so if someone dies in year 2003, then they're kind of not really around to commit crimes, property or violent offenses. I know that this is the share, so it's just computed among those who are living, but do you have any evidence that the people who are dying kind of in this earlier window, or maybe more extreme addicts, or that they were somehow different than the people who were sticking around to the end of your sample?
We haven't looked at that, no, but we should. I think so. We've for like mortality as an outcome, we can also use like duration type models, like or a logit to try to account for this censoring. I think that would, but I need to think about how that would be affected by. So essentially, what we're doing is estimating the effects of various time periods on the individual risk of mortality or offending. So it's something we need to think more carefully about in terms of the potential influence that might have. But I think it might actually go, well, yeah. So it would be the more, if it's the more criminogenic or more high risk people dying off early, then we might expect lower rates in the future. Yeah. But it's something we can certainly look into. Violent offenses, we see this short-term increase in violent crime, kind of starting at the onset of the supply reduction. Cocaine offenses, amphetamine offenses, so this is where you see some pretty striking patterns with potential substitution to these other illicit drugs. And basically what I'm going to do now is to put some numbers to those pictures, controlling for things like age. The way in which we're going to model the first set of estimates that I'm going to present is an event study design where we're including a linear trend for that pre-period from 95 to the third quarter 2000, and then we're going to estimate deviations from that pre-trend for the post-period. And what I'm going to present is averaging effects. We estimate quarterly dummies, and then I'm going to average them in groups. So a short-term period in 2001, medium-term period, and a long-term period. Yeah, Zach, question?
So in terms of like the property and violent offenses, do you know what types of crime, like types of property or types of violent crime that those are?
We can drill down. In terms of the property crime, most of what the property crimes are theft. But if we look separately by different types of crime, like theft, breaking and entering, we see very similar patterns. We can also look at different types of violent crime, like assaults and sexual assaults, I think. We don't have domestic assaults, but it's pretty consistent across the different subcategories of crime, which is something we haven't included in the paper yet, but it's something we've looked at.
But also, like, say within theft, like, could you know, like, what they stole?
No. I mean, all we would know is what they were charged with, so we wouldn't have more detail than that. So the outcome of interest, you've seen those outcomes. We're going to have this trend in there for the results. I'm going to show you robustness to including a trend or not. Indicators, these are the kind of the key effects that I'm going to be communicating in this event study design. And then we're going to control for age. We can include age fixed effects or a polynomial. Controlling for gender, indigenous status. I'll show you robustness to including individual level fixed effects, and results are very stable across those different specifications. And as I mentioned, I'm going to summarize periods into, this should just say 2001, not 2001 plus 2001, but in a short-term, medium-term, and long-term period. One thing that we've done, which is not, our results are not sensitive to this decision, but we've dropped the observations in this quarter that this supply reduction happens. And so that's this dashed period that you've seen in these graphs. And so essentially what you want to think about is a trend in outcomes being fit in this pre-period, and then our estimates measuring kind of on average the deviation from that trend if we continued it into the post-period. Identification, so I don't have a lot of time to talk about this, but obviously we need to think about, are there other changes going on? So changes in policing practice or procedures. We don't find any evidence of this. We don't have any evidence or found any evidence on changes to how these individuals are treated by the health system. So whether there's, the needle exchange or syringe programs, the eligibility for this therapy programs, ambulance protocols, naloxone use, things like that. The shortage did appear to take both users and policymakers by surprise, so we don't have concerns about some sort of strategic behavior in anticipation of the shortage. And we also can check whether we don't find any that results are driven by incapacitation in the sense that all the heroin users are locked up into prison, and that's why we see reductions in a lot of these crime patterns. We only have incarceration info from 2001 on, but we can look to see if that's an important explanation, and it's not.
Can I push back on
Yeah,
your
yeah,
assertions
please
a little
do,
bit?
yes.
So I mean, I Googled this earlier today, this disruption.
Right.
And I've got like a New South Wales governmental website that basically is providing quite a few cases that sort of dispute your sort of identifying assumptions. Like 2001, there was a safe injection site established in New South Wales.
Okay.
That like, and it seems like even the seizure was part of a sort of coordinated policy strategy for what the government was recognizing.
I mean, I know there was a meeting where they were discussing on how to address this opioid epidemic. From what we've seen, there's not been any major local changes to how things were being done in New South Wales. I'll look into the safe injection site. That was something that was, I think, fairly prevalent. At least I know in terms of the needle exchange programs, there was a lot of that available in the 1990s. The injection site I'll look into, but yeah.
And this is sort of centered around, like my earlier question about sort of any type of differential supply shocks.
Right, across different locations.
Yeah, so if you're just using sort of this national supply shock that may or may not coincide with a lot of other sort of policy responses that could affect your outcome variables, your identification, you know, if you could find any type of cross-sectional variation or something like that, you could seriously improve, I think.
Yeah, I mean, that's something we've thought about, but we haven't found that kind of magic strategy. I mean, to see if there's other major things going on that would have not been heroin or opioid related, we can look at these other criminal offenders, and we don't have evidence for that, but I think your point is well taken in terms of, you know, maybe we're leaning too heavy on this, these seizures or the supply side. We need to do more to check what else might have been going on in the criminal justice system. One thing that we've checked, and I haven't had time to put it in the presentation or the paper, is whether the punishment associated with getting arrested for an opioid offense changed in any discontinuous way, or so there was any change in kind of the prison sentencing or anything, fines or anything like that, and we don't find any evidence of that. And you know, I think the discussions, a lot of the papers we read, there's a lot of those researchers are leaning pretty heavily on there not being a lot of other local things happening right at this 2000 or December 2000. But I agree that in 2001, 2002, there may be other things going on that help explain the persistence of these effects. So I take your point, and I'll look into that a bit more.
I noticed in the references that some of the research has looked at foster care and how it's related to heroin addiction. And I wonder if this sudden reduction in the availability of heroin in Australia had an impact on how likely children were to be put into foster care, given that 32% of the heroin addicts are women.
Yeah, I have not seen anything that's looked at that. I would imagine that there'd be, and I don't have any knowledge of what the foster care system is like in Australia and how that differs. But it's something that I can't comment on at this point. But it could be something else that's important that's going on. So yeah, I'll make a note of at least looking to see if anyone else has discussed that. Catalina, did you?
Yeah, I just had a question. So the data is all reported crimes.
Reported crimes, right. Well, it's not even as good as reported crimes. It would be people that are charged with an offense.
Right.
And so...
Similar to like the Unified Crime Reports.
Well, not even that good. It would be like taking... so uniform crime reports might capture when individuals call and report a crime to the police, even if no one's ever caught or arrested. What we're seeing is at the individual level, whether someone's arrested or charged with a crime.
do they have any sort of, it would be great to see if they had any survey that had individuals.
Yeah, so
Or people that
these,
they have used more or not.
right, no,
research.
these injecting drug user surveys very clearly document this pattern of
Yes.
heroin's very easy
So
to
that's
find,
not
lots of people are
related.
using it. Afterwards, heroin's hard to find, and those surveys also document this increase in cocaine and amphetamine use.
So that is not related to any, any changes in prosecution of these crimes or?
Right, no, and I don't,
whatever.
yeah, and I think that we need to do further investigation of this, but from what we've come up with, it's not a major explanation. Let me just kind of skip through this because I know I'm running out of time, but we're going to control for these age-related changes in offending, other characteristics, and then have this counterfactual or difference in difference type specification as well to help account for any other time-specific trends or changes in offending in New South Wales. We can remove or add in trends and also add fixed effects and look at this diff and diff type, which I'll get to, and I'll talk about how we construct that curve. Okay, so mortality outcomes, this is just putting numbers on those pictures that we saw, controlling for these factors. The mortality is reduced by about 40 to 50%, depending on what you're looking at, but any cause mortality, we see very large reductions, and this is driven entirely by the reductions in the opioid-related mortality. The drug offending results, we saw this for the opioids, very large and sustained reductions, and then the short-term increases in cocaine and amphetamine use, short-term increase in property and violent, and long-term declines in property. And as you saw in the pictures, the magnitude of these effects are very large. So based on, now it's really raining, now it's Simon. So based on the average effects for, say, cocaine, we see a 200% increase in the amount of cocaine charges in that short-term period during 2001 relative to the mean just prior to that shock, or just prior to the onset of the heroin shortage. So the heterogeneous effects that I mentioned, well, I'm going to show you here. There's a lot of different ways we can do this, and we're still exploring different ways of looking at this. What I'm doing here is a pretty rough cut of just looking at whether an individual had any sort of participation in the opioid substitution therapy during the Q3 of 2000, which was just prior to the shortage, and something in Q4 of 2000. It's similar, same results if we just look at participation in Q3. And this is a lot of individuals. This is about half of our sample. One limitation is that and we need to learn more about the treatment data, but what we observe is the entry and exit into these programs, and we observe the reason for them exiting. And sometimes I think what we're having in this participation is individuals not being coded as exiting these programs. And so we might have individuals that have an entry date with no exit date, and we don't know if they're still participating or if they exited and it just wasn't recorded. So that might capture a lot of these users in this sample, but we're trying to look at ways of defining more active participants at the time of the shortage, but this is the first cut, and it's about 50% of the sample. And so if we interact that indicator defined as participating in the methadone program right at the onset of that shortage with these period or these quarter indicators, and then averaging across these periods, and this actually is dropping the Q4 2000 and just using 2001, we see a really interesting pattern, or at least we think is interesting in terms of overall these are very similar to the effects we saw for the full sample, but if we look at the group that was participating in the substitution therapy, we see almost complete elimination of the increase in property crime for those in treatment at the time of the shortage, and less violent crime, suggesting that this treatment is in some way mitigating or reducing that short-term cost in terms of the increase in these types of criminal activities during that shortage, during that period where there's a heightened amount of crime. Yep.
Sorry if I missed it, but what is the intuition behind the short-term increase in substitution of other drugs and then dropping off?
Again, I think this is at least the, I think the most likely explanation, and this is another thing that I'd love to get feedback on or your guys' thoughts on, is that I think that these individuals who are very actively participating in, these daily injectors of heroin and often using polydrugs were continuing to go to these dealers and using these alternative substances and potentially getting caught with these substances, but they weren't getting, maybe they weren't, that wasn't as satisfying to them, and then they, chose to stop that habit, or I don't know what the story is there, but that's my, and we need to talk to more drug policy experts about this in terms of why would it be so short term. I think one thing, and I'm just go quickly back to the price, one thing that could be quite important is, I didn't realize so far back, is this, after 2001 the price did start to come down, and relative to this increase this looks pretty small, but for the price you would be paying, or the purity of the expected substance that you're getting, and this would be, this price might be quite different than this high price here. So that short-term substitution might be those really heavy users or addicts substituting to what they could get, and then once this came down a bit, they maybe could afford that more expensive heroin, and then we're substituting back to that.
But then you weren't actually seeing the increase in heroin use again.
Right, yeah, no, that's a good point. So yeah, that might not be part of the story. This, as you can see, this is still kind of work in progress, and we're still trying to think. There's some of these patterns are a bit perplexing in terms of what the underlying behavioral model would be. Yeah.
So I'm confusing myself here, trying to understand like the constellation of results. So you find evidence that people are, there's lower rates of mortality after the shortage.
Right.
And there's not any evidence that, do you find evidence that enrollment in the methadone treatment goes up?
So it's not something we presented yet because we're still working on kind of the rules of entry into these programs. I can tell you that we've looked at the data and we don't see this huge flow or substitution into methadone treatment, which is quite surprising. What we do see is those that are in treatment are less likely to exit early or exit with that code of not having shown up for their treatment. So the persistence in treatment is stronger for those that were treated, but we don't see these large increases in treatment. And so that we're trying to understand why this pattern or how this fits with the results.
Because there's like pretty high rates of mortality associated with withdrawal from daily heroin usage, right? I mean, that's one of the sort of policy goals of these methadone clinics. So yeah, if you see these people who basically cannot afford heroin anymore, you're sort of telling us a story about, and this is not accusatory, but you're spinning a story about sort of substitution to cocaine or something like that. But unless that's operating on the same chemical pathways,
then there would be.
I would expect to see in the short term at least an uptick in mortality. If they can't access the drugs, which is sort of making me return back to sort of contemporaneous policies that might be.
Yeah. No, that's a good point. I think that I think back then with this mix and like the purity of heroin and the overdose risk associated with using heroin and injecting heroin, I'm not sure if that kind of uptick in mortality or that withdrawal effect would be as strong in this time period as say it is, in the US today in terms of what mix and purity of heroin that people are using. So maybe some of that has to do with the quality of the drug in terms of that expected increase in overdose risk, but that's just pure conjecture. I'm not sure about that, but I think that it's not something we've considered, to be honest, is this effect on how withdrawal might affect things like mortality. That's actually something that is a really good point, because with this, we've been wondering how we can use this other health data. So in terms of the hospitalizations, And this is all post, so starting in 2002 with a lot of this data, but we might be able to get a more full idea of kind of.
Do you have, I mean, so would you be able to tease out the shock on people who are not participating? Well, no, because you wouldn't observe them. People who are not participating in a clinic at the time of the shortage, who don't, you only observe them if they opt in at some point. You wouldn't observe them if they die, right?
Right. So the heterogeneity analysis, splitting by whether they're participating or not,
Yeah.
we have to condition on them being alive during the time of the shortage. But
So there might be a sample selection issue with respect to the mortality.
Yeah, no, I think so. So yeah, we'll think about this a bit more. Zach, you have something?
Is the supply of methadone pretty stable over time? Like, do the people ever go to these clinics and have to turn them away?
That's what we're trying to figure out, and we don't have a lot of information on. All we see is just data with their, identifier that we can link with the other data, but the entry. So what we see is their entry date, exit reason, the dose that they have at the entry, and so this is something else that we can use to try to get at an intensity of addiction and potentially looking at the intensity of the effect on different types of individuals, and the max dose that they received during treatment. So we haven't used that information, but I think to your point, we need to think about how to use that more completely. I just want to show some robustness results, and then I'll conclude. This would be just taking, the demographic controls that we have, adding. We can have very flexible controls for the amount of time we've seen you since your first treatment episode. That doesn't affect results at all. When we remove the pre-period linear trend, and so this would just be dumbing out both the pre and post quarters and then measuring these effects relative to the baseline right before the shortage, we see very similar effects, which suggests that those, the pre-trends are fairly level. And then the diff and diff, what we've done for now, and this is also something that's fairly preliminary and work in progress, we've taken all of that data on the criminal offenders who didn't have any sort of participation in the methadone treatment or opioid-related offenses. We've created a matched group that's the same size, and we're matching on age, demographic characteristics, and in some cases we can match on kind of pre-shock offending for other types of offenses. And so once we do that and we run a diff and diff, or interacting these quarters with the treated group, or those those ones that were in treatment, we see fairly similar effects. And this is for mortality as well as for a lot of the offending results, which suggests that there's not something else that's affecting. Well, one, it suggests there's not huge spillover effects to these other non-heroin groups, but also it suggests, and the effects are slightly smaller, which may be because of a spillover effect, but it suggests there's nothing else major going on in New South Wales, like a general decline in property crime, for example, here, that's completely explaining our results. If anything, in the long term, controlling for the property crime for that matched control group, we see even larger declines for that treated group. And so that's reassuring that we're not picking up some other aggregate changes. And that's true. Our results are robust, strongly robust across these different crime categories. So let me conclude, and apologize for going 2 minutes over now. We think this paper, this project so far helps illuminate these relationships between heroin markets, other drugs, and important social costs. You've seen kind of the main results. One thing that I think I'll just end with is that in terms of the property crime effects that we're estimating, so this line here, and especially in the longer term, there's been a decline in property crime in Australia and in New South Wales in general since 2000, late 2000, early 2001. And so this is a pretty important explanation as to why we saw property crime fall. And our back of the envelope calculation suggests that about half of the drop in property crime over this period in New South Wales can be attributed to just this estimation sample. So these 30,000 individuals that we see committing less crime that we think is mostly due to the interruption or disruption of the heroin market and sustained kind of supply reduction. So I'll conclude there and thank you for your time and attention and wish you luck getting home and